Thank you.
Well, thanks so much, Teresa. I appreciate it. And we are super excited to be here with you this afternoon to share, as you mentioned, about our new clinic, to talk a little bit about just some general services that we offer for those of you who may not be familiar with us at Shriners Children's Twin Cities, but to really focus our conversation this afternoon with our two speakers, Sarah Rowley, who is one of our physical therapists, and Allyce Fisk, who is one of our physician assistants here at Shriners Twin Cities, who will be talking more about the process of a patient becoming a registered patient here at Shriners Children's Twin Cities and the internal referral process into our rehabilitation services. And I know, especially as we are all in the midst of this pandemic and kind of flexing in how we treat and care for our patients, that idea of video visits is hugely important, especially I know for many of the patients that you may be working with who are medically complex, where there absolutely is a concern of them leaving the home. We can talk through how we can not only provide the best care and the best treatment plans, but also be able to incorporate that virtual component so that we can keep families at home that need to be at home when at all possible. So before I pass it over to Sarah and to Allyce, I'm going to share my screen here. And what I'd love to do is just give those of you who are not familiar with us a little intro to Shriners and what we do and who we see. We'll see if my computer wants to share the full screen here. But just to start us off, so as Teresa mentioned, my name is Dana Kernick-Tyson. I am the Professional Relations Manager at Shriners Children's Twin Cities, and my focus really is to act as a physician liaison, as well as be able to just support our endeavors within our community as well. So for those of you who aren't familiar with us, Shriners was actually founded in 1922. In fact, here in the Twin Cities, we were on the same plot of land since 1923 in our old hospital location. So we're a network of 22 healthcare facilities, really specializing mainly in pediatric orthopedics, but we do have a few locations that specialize in burn care, cleft lip and palate, and spinal cord injuries. So you can see our map there, looking at all of the different locations we have across the US. We do also have 2 international locations as well, one in Montreal and one in Mexico. So our mission overall, the most important thing is really to provide the highest quality medical care and surgical care to children with orthopedic needs within an environment that is family-centered, collaborative, and is just really comfortable for that patient experience. Another huge component about Shriners, really what kind of started our mission as a whole, is to provide this care without regard to the ability of a patient or family to pay for services. So while we do accept most major insurance carriers, we also work with families that are underinsured or uninsured or maybe undocumented. So a good opportunity for us to be able to provide this care to those who may not otherwise be able to receive it elsewhere. Our Twin Cities location has a really large geographical service area. So this map actually shows all of the areas that we serve. We work with patients in Minnesota as well as the surrounding 6 state areas, and then 3 Canadian provinces as well. Today, as we're talking specifically about rehabilitation services and looking at the virtual component of that, we're really focusing in on our Minnesota families. While we can see a patient in person and via video visit from any of these locations when we're thinking about physician visits, when we're thinking about the virtual visits with rehabilitation, we're really just focused on Minnesota at this point in time. So I want you to keep that in mind, especially as you may be working with families who are outside of that state of Minnesota. As Teresa was mentioning, we just recently moved. So I shared that we had been on the same plot of land since 1923. It was a pretty big move and adjustment for us, but we are absolutely loving our new space. So we are now located in Woodbury, Minnesota, just about 20 miles east of where we were before. We're at 215 Radio Drive on the lower suite of that space. And I have just a picture of our new lobby. It's very pediatric, very colorful, very vibrant. And we're so far just loving the new space and have had a lot of good feedback from our patients and families as well. So in regards to the conditions that we treat, By no means I'm going to run through every single one of these on this slide. I recently sent over to Teresa some of our information in PDF form, since I know not everyone is physically in the building, so it's harder to get physical copies of things to everyone. So I did send her those, and she can forward that information along. But this just gives you a general sense of kind of that pediatric orthopedic component, really the conditions across the board that we are treating and we are seeing within our walls. Now, as you're looking through some of these conditions that we're treating, of course, there is absolutely an orthopedic component to it, but we also have many of these conditions that have other specialties that we need to have available to provide this wraparound care. So as we're looking at our team, we really consist here at Shriners Twin Cities. Our main doctors are Dr. Christopher Vera, who is kind of in that upper.
Can you please come to the front desk?
Sorry guys, a little interruption. But Christopher Vera, who is pictured kind of middle of the page here, he specializes in treatment of scoliosis, so adolescent, congenital, early onset. He also focuses on limb deficiencies, spina bifida, orthopedic trauma. Dr. Michael Priola, right above him, pictured at the top there, specializes in treatment of sports-related injuries, shoulder, knee, ankle, conditions of the spine, CP, foot deformities. And then we have the lovely Allyce, who you will meet in a little bit, and Mary Aschenbrenner, who are our two physician assistants. You will notice, though, that we have a lot of other providers that support us, highly specialized folks from places like the University of Minnesota, Mayo Clinic, and Gillette, who support these other specialty areas for many of our patients who need care beyond just that orthopedic support. So when patients are coming to see us—
Michelle, can you please come to the front desk? Michelle, can you please come to the front desk?
So when we're looking at these provider visits, our patients are seeing us in the outpatient clinic. Like I mentioned, we really have a multidisciplinary team approach as we're looking at providers themselves, but also as we're looking at our ancillary services and all of the departments that support us within as well, which Sarah will be able to speak to in terms of rehabilitation. We do have specialty clinics that support specific conditions. For example, we work with patients with spina bifida on the second and fourth Friday of every month, where we bring in those other specialists that would need to see those patients. And again, as Teresa mentioned, just especially with the new clinic, not only in appearance, but also in feeling, we want to make sure it's a very family-centered approach. We do continue to provide surgical services. However, since we no longer have an inpatient unit in our new building, we work with other children's hospitals in the Twin Cities to make this a reality. So Dr. Vera and Dr. Priola will work at these other locations in their OR to provide those surgeries. So without further ado, I would love to pass it over to Sarah Rowley, one of our physical therapists, have her share a little bit about herself, and then she'll share more of this focus on the rehabilitation services that we offer.
Well, thank you very much, Dana, and thank you all for joining in to learn a little bit more about what it is that we do here at Shriners. I have been a physical therapist here for 25 and a half years. I like to get that half year in. And one of my favorite things about working here at Shriners is that we really get to be involved with these kids as they grow and see them over their lifespan. And this is a picture that really is reflective of those relationships that we get to build with our families. It's not at all uncommon for us to start treating a person in therapy services when they're a toddler, and then we end up getting graduation invites and things like that, because we're still a part of their lives as they move forward into the young adulthood timeframe. In rehab services here at Shriners, we have physical and occupational therapy. We do not have speech therapy services because we are an orthopedic focused institution, and that falls outside of the orthopedic realm. In physical therapy, we work primarily on large body gross motor movements. So those big movement transitions like getting in and out of chairs, walking, going up and down stairs. We also tend to focus on rehabilitation for lower extremity surgeries and injuries, as well as any kind of sport injuries that occur. We have therapists that are specially trained in scoliosis-specific exercises, which I'll touch on a little more detailed in a moment. And we also work on providing mobility equipment for children. So things like walkers, crutches, wheelchairs, that falls under the PT umbrella here at our clinic. Occupational therapy will work more with those fine motor skills, so things that involve school-related skills, activities of daily living, such as hygiene and feeding, as well as rehabilitation from upper extremity surgeries or focus on upper extremity concerns. They also do a lot of custom hand splinting here as well. Next slide, please.
Looks like it's freezing on me a little bit here, Sarah. Let's see if I can. Might have to exit out here. Hold on one moment. Let's try this again.
It's the love-hate Zoom.
Oh my gosh, I know, right? No kidding. All right, let's try this. All right, there you go.
There we go. So scoliosis-specific exercise is a specialty program within our rehab services department. We have a few therapists that have gone on to have specialized training in the Schroth method of exercise for treating scoliosis. I think Schroth was a proprietary name, so we've altered it a little bit to be called the scoliosis-specific exercise program. These therapists have specialized training in looking at kids with scoliosis. Typically, it's the adolescent idiopathic scoliosis diagnosis that is most appropriate for this type of exercise program. They're well versed at analyzing the details of the curve as far as looking at the x-ray as well as looking at the child and thinking about the different kinds of postural corrections and stretching and strengthening exercises that can be taught and practiced with the child in order for them to have an active role in trying to correct or slow down the progression of their curve. These exercises are pretty intense. Each program is customized. And when I say intense, I don't mean intense in necessarily the difficulty level, but in the frequency in which the children are asked to participate in doing the exercises at home. The program is designed to be done daily, and then the therapist will meet with the kids periodically after the initial kind of burst of therapy in order to get the kids started in learning their exercise program to fine tune and adjust as needed. There are not very many therapists in Minnesota that are trained in this technique, so it's a unique service that we really are able to offer here, and one that's often pretty well sought out by those kids that fall into the right treatment category and are motivated to participate. Next slide, please.
Apparently it is just wanting to freeze up on me. My apologies. Now it won't even let me escape. There we go. All right, let's try this again.
We're all in separate rooms so we can be unmasked.
I know. So, it might be the detriment of that. All right, there we go.
Yeah. There we go. I think there was one slide. There we go. That's the one I'm looking for. So this just shows some of the pieces of equipment that we can provide through our rehab services department. We have a special program that has funds raised by our Women's Auxiliary to help cover wheelchair expenses for those families that don't have coverage for that. We also do a lot with providing activities of daily living equipment, so things that will aid independence in hygiene, dressing, feeding, recreation, and school skills like specialized scissors, pencil grips, etc. And then the bottom picture shows our capacity to do some customized splinting here. So we have a variety of different upper extremity splints that our occupational therapists work to make, some of them from a flat sheet of plastic all the way up to fitting and customizing something that's a little more off the shelf. So it's whatever meets the child's needs is what's provided to them. All right, And then we're able to go on to the next slide. And I think I'm going to turn it over to Allyce at this point, or Dana.
Yes, I will chat a little bit about this. Thanks so much, Sarah.
You're
So
welcome.
when we're considering the referral process for patients to find us at Shriners Children's, we want to make sure, as I mentioned earlier, that whether they're coming to see one of our providers, whether there is anticipation on them working with our rehabilitation team, that they are registering formally as a patient with Shriners Children's Twin Cities. Therefore, what we will be asking is if you have a patient who, you are considering, gosh, rehabilitation services at Shriners would be fantastic. We really want to pursue this. What we will ask you to do is to submit and complete a referral form. We do have one that I sent along to Teresa that she can pass along to you. Otherwise, we're happy to accept your referral form that you utilize as well. But we'll have you complete that information, send that referral form via fax to the number listed or via email to the email address listed. And again, all of this information is on the referral form, so no need to memorize it or jot down notes. I'll make sure you have that information. You can also call our patient referral line if you have any questions. And if it is an urgent fracture or an urgent injury, we do have a nurse triage line as well that you can call, which will make sure to get patient in within usually about 24 hours. So when you're completing that referral form, of course, we have a notes section, which, as we all know, knowledge is power. So the more information that you can put in there, especially as regards to what the intent is, whether it's to see one of our orthopedic specialists, whether it's to do work at rehab, that is super helpful for us. Once that information is received, then what we'll do is have our intake coordinator directly contact your patient and that family to schedule their initial appointment. And this is where Allyce Fisk, our physician assistant, comes into play, as she then takes on that next step of meeting with that family and determining if an internal referral to something like our rehab services is appropriate. So I will pass it over to you, Allyce, if you want to share a little bit about yourself first, and then we can move into your content.
Well, as Dana said, my name is Allyce Fisk. I'm one of the PAs here, and I've been at Shriners not nearly as long as Sarah, but I've been here for about 1.5 years, and I've been in orthopedics since 2012. So lots of fun orthopedic experience over the years in different specialties, including adult and pediatrics. And it's just a privilege to be here at Shriners. It's a great facility. It's a great collaborative team environment. And I think all of us just love showing up for work every day and helping the kids that we see. So, so thanks for having us today. We're really happy to be here. So as Dana said, there are multiple ways that you can send us a referral. Typically, whether or not we need to see the patient in person versus a telehealth visit, which we'll talk a little bit more about in the upcoming slides, will be determined on the complexity of the patient. So knowing kind of the background of some of the patients that you guys will be treating, it's most likely that the patient will be needed to be seen in person initially. And that can be done either by myself or our other PA, Mary Ashenbrenner, or by any of the physicians that we have on staff. So depending on what the patient needs to be seen for, we will, make sure that they're seeing the appropriate person when they come in. If it's a patient that for whatever reason is already established with an orthopedic provider and it's really something more that they need physical therapy, rehab resources for, and not so much a full orthopedic evaluation initially. I apologize, my light is having a little bit of a flicker here. But then we can see them most likely via our telehealth services or fast track video visit, and get them just kind of in the system, do an initial evaluation via video visit, and get them over to therapy. So if you don't mind, Dana, going to the next slide, I think we'll talk a little bit more about the fast track video visit process. So here at Shriners, what we usually use for fast track video visits, which is just our terminology for a telehealth visit, is an app called Blue Jeans, which is really convenient. We've used it frequently since COVID started, and it's been fantastic for both us as providers and for our patients. It's an app that the patients can download on their phone or tablet or computer. I would say for most people and from a provider standpoint, it's much easier if the patients can do it on a laptop or a tablet where they can be a little bit more mobile. If they're on a desktop computer, that can make things a little bit trickier for us as far as doing our physical exam and evaluation of the patient. But either way, what happens is they are scheduled for that visit and we log in just like we do similarly for a Zoom call. And we can do a video visit with the patient, do an exam, and get their history as far as what they're being seen for orthopedically. Mind going to the next slide, Dana? So in order to prepare for these visits, obviously the patient would need access to the electronic devices that they would use and then also internet access. So if this is something that is not available to your patients, then we would be happy to see them in person. And we do have a fair number of patients that don't have access to these resources, so we would see them in person instead. And then when they're scheduled for these visits, someone will walk them through how to download the Blue Jeans app, and they will be sent electronic forms to do their consent process and make sure that all their questions are answered. And then we will usually send them an email that includes lots of information as far as how to set up the app, but then also how do they best prepare themselves for the visit. So things like choosing a well-lit room, making sure that their location has enough space for them to do the likely things that we would ask for them to do during the exam, and then also just appropriate clothing, which seems, you know, commonsensical to us, but for a lot of the patients may not be something that they would know to think about ahead of time. Next slide, please.
All right, I'm going to take it over from here now to talk a little bit more detailed about the rehab evaluation. I'm going to kind of discuss it broadly and then drill it down a little bit as far as how we would do this in a telehealth mode. So typically when we see kids for a rehab eval, the determination as to whether or not PT or OT would be the most appropriate service for the child has already been made by the physician or PA that has done the initial visit with the child. Many of the kids get both PT and OT depending on their needs. When they come in for the evaluation into our therapy department, typically we want to know from the family a little bit about the child's medical conditions, what their experience with therapy services has been in the past, and then trying to determine what their areas of difficulty are that they would like to address in therapy. One thing that we're finding with their telehealth visits in particular is that sometimes families are seeking these services right now because the kids are not going to in-person school, and they therefore are not getting the school therapy that they typically would be getting. Just not having school therapy services is not typically a reason that we would be able to see the kid for therapy services here. They really need to have a specific function that they wish to work on, or some decline that the family is noting because the child's not getting therapy services, in order to have a medical reason for participating in therapy through Shriners. Because we have to operate within the medical model, which is different than the educational model that the school therapist can work in. Next slide, please. So I don't know how familiar you all are with what occurs in a PT evaluation or an OT evaluation, so I thought I would kind of touch on some of the main things that we do tend to look at. We use a variety of techniques depending on that area of concern and difficulties that the family has told us about. So we may be doing things like measuring joint range of motion and muscle flexibility with a special measurement tool. We would be assessing strength typically and muscle tone, be it low or high, with some hands-on techniques and resistance provided. We have a variety of ways of assessing sitting and standing balance, both general as well as very specific with standardized assessments. OT will tend to look at a lot of those activity of daily living skills, and PT will tend to look more at those large body movement transitions, as I talked about earlier. And then things like functional mobility, walking, being able to transition out into the community or within the home environment as far as how the kids get around is another thing that we look at. And then if the primary concern is that the child is behind in fine or gross motor skills, we do have specialized, standardized assessments that we can get a very detailed look at where the child is at in those areas as well. Next slide, please. So as I was recently discussing, many of the techniques that we do to assess where a child is in these areas really requires us to put our hands on the child. For instance, muscle tone is very hard to assess without being able to feel what the muscle feels like. So as with the initial therapy visit, we prefer to do the evaluation in person if possible, just because we can get those more detailed pieces of information. We certainly can work on the evaluation via a telehealth mode, but we'll only be able to get kind of generalized information. So for instance, if we wanted to know what someone's hamstring flexibility was, we could give a visual estimation of that, but we wouldn't be able to use our measuring tool to get a very detailed measurement of that. And this general information certainly is enough for us to set up a rehab plan of care. It just might limit our ability a little bit to sort of plan for the interventions as we move forward. But we can certainly work around whatever works best for the family. Next slide, please. If we do the therapy evaluation via a telehealth, we really want to have a caregiver there during the evaluation to be our hands for us. So that caregiver needs to be comfortable touching the child, moving the child, handling the child, and able to follow any verbal and demonstration instructions that we would provide. So an example of this would be back to that hamstring flexibility again. That needs to be measured in a certain position. And so we would be able to provide some verbal and visual demonstration as to what that position would be, but then the caregiver would have to go ahead and place the child in that position so that we could provide a visual estimation of that muscle flexibility. Next slide, please. So once the evaluation is completed, most of the teletherapy ongoing visits that we've done have been following an in-person evaluation. That gives us that initial touch point in person to maybe provide a little bit of equipment that the kids may be needing to do the subsequent therapy visits, and allows us, as I said, to make a little more detailed assessment of where the child is at. And then from there, we tend to jump into the video visit. The video visits, we do require a caregiver over the age of 18 to be present and right there with the session during the whole therapy session. They are often called upon to assist us, again, by being our hands-on assistance if we need that. Or in the instance of, for instance, if the OTs were working on some feeding techniques, they may have to have setup of the feeding environment with any specialized equipment that might be provided, and then providing the hands-on assistance as the OT works with the child on the different feeding techniques. So again, we'll be there to walk the caregiver through every step of the way. But the anticipation in advance of the video visit should be that both the child and the caregiver will be present and actively involved the entire time. Next slide, please. Older children that can follow directions really well and who don't require a lot of physical assistance are often able to participate in the therapy visits with very little caregiver assistance. And so it's sometimes we run into the thought is, well, my child's a teenager, you know, they're doing their exercises by themselves. Why do I have to be there? And we do require the caregiver to still be present, and that is because of internet safety. So our video platform is quite secure. But, you know, we've all heard about Zoom bombings and things like that, as well as just to make sure that the child is comfortable with the interactions of the activities and exercises that we're asking of them. We do want that caregiver to be there. There are some interventions that really don't lend themselves well to telehealth visits, and this kind of is tying into this internet safety piece. So activities of daily living that might be privacy sensitive, such as toileting or bathing, we cannot do online. Some things that really require hands-on molding, for instance, of a splint to an upper extremity, or fitting of mobility equipment would have to be done in person, as well as if the child would require some manual therapy techniques, like application of therapy taping, things like that would have to be done in person as well. But many of the things we certainly can do on a telehealth platform. Next slide, please. We do take a lot of safety precautions when the kids do come in for an in-person visit, and as the clinic as a whole as well. But these are some that are really specific to the rehab department. So if the family and the care provider has decided, well, maybe that in-person evaluation would be best. We tend to be a lot less busy earlier in the morning. So if you would be more comfortable coming in when there are fewer people around, taking an early morning time slot, oftentimes we can't guarantee, but we can say with pretty good certainty, you're probably going to be the only person in the department. So that really allows for that decreased density of the number of people that are around during this pandemic. We also use physical distancing during the evaluation when we can. So I've talked a lot about that hands-on, but when we're discussing or if we're providing a demonstration and the child's able to do the movements on their own, we tend to try to keep that minimum 6-foot distance between ourselves and the children and the parent as well. We have masking by everybody universally in the clinic. And also universal eyewear protection. So that's protective both for us as well as for our families that are coming in. And we also ask that parents and care providers that come in with the kids and are masked also. If the children are under the age of 2 years old or have cognitive delays or medical conditions that prevent them from wearing a mask, we certainly will make an exception, but the staff will be masked. We also try to limit the number of people in the rehab department by asking that only one caregiver and no siblings come along to the therapy appointments, just so that we don't end up with a bunch of extra people running around that don't really need to be there. And then we have lots of wipes and sprays. We're copious sprayers of any toys, mats, or equipments that are used during the therapy sessions. Next slide, please. And I think I'm going to be turning it over to Dana here to talk a little more about the overall clinic precautions that are being taken during the COVID-19 pandemic.
Yes, thanks, Sarah. So this is just a little infographic. You know, Sarah pretty much covered all of it, but of course, that's a time where we need to be extra cautious. We are seeing families that do have medically complex children, and we want to just really ensure safety in every possible way. So from a clinic-wide perspective and a system-wide perspective, really, we are doing temperature checks upon arrival to our building. So right as you enter our front doors, we're doing temperature checks, and we're also asking those necessary screening questions. We do have enhanced cleaning protocols. As Sarah was mentioning, everyone is wearing masks. We are being asked to wear the surgical masks as well to ensure that we're switching those out on a daily basis, that those are clean. And then of course, social distancing, making sure that we are physically distancing that 6 feet at least. So you'll see that throughout our clinic as Teresa experienced with her tour. So without further ado, I have my contact information here on the page if any of you have questions in the future that you need to reach out or want to get connected with Sarah or Allyce. I'm happy to help coordinate and liaise in that way. Teresa does have that information as well, so you can get that from her. But I will stop sharing my screen here and I believe pass it over to Susan if there are questions that you would like to share and have Allyce and Sarah be able to answer live here.
Yes, great. Thank you, Dana and Sarah and Allyce. We do have a couple questions from Judy Gill. And hang on, I just lost them now. So I have two questions. First, what is the age limit for referrals? And the second question is, do you provide the mobility devices for your patients, or do you use a home care company for the device and then you make modifications? Those are the questions.
Perfect. Allyce,
I
if you
can
take the one about
tackle
age
that
limit.
first question. Yeah.
Awesome.
So as far as age limits go, we do see kids up to 18 here at Shriners, and we'll see kids all the way up until they're 21 years of age if they're established with us and they're receiving equipment or receiving ongoing cares. So for instance, if a child is 19 years of age and they need hardware out from a previous surgery that we had provided for them, we certainly can see them until, you know, they're 21. But if it's a new patient, we are not taking patients over the age of 18 at this point in time, unless things have changed in the recent past. But that would be kind of our cutoff. And then Sarah, do you want to tackle that second question with the mobility devices?
Yes, certainly. We have a budget to help families with obtaining some mobility devices that we have samples of right here in our rehab department. So this would include things like forward walkers, reverse walkers, underarm or axillary crutches, as well as forearm crutches, single point canes. So those are things that we just have a budget for. We tend to have the equipment here, and then we just give that out to the families. I don't think we're even billing or trying to recoup any of the costs for those pieces of equipment through a child's third-party payers. There are more expensive pieces of mobility equipment, however, that our budget is not able to help cover. So if a child needs something like a gait trainer, which is a really beefed up walker that has a lot of additional or extra support, we would try to work with a vendor that is an approved vendor through the child's third-party payer, so that the family wouldn't be stuck with a bill for that piece of equipment. The same would go for wheelchairs. If there is a requirement to work with a certain vendor, we can certainly, particularly here in the Twin Cities area, work with that particular vendor. Most often we're working with an equipment vendor for our wheelchairs that is out of St. Paul. The company is called Rehabilitations Designs, and I think that they have, I think they're in-network equipment vendors for quite a few different third-party payers. And we have been in a long working relationship with them with the wheelchairs, such that they come right over here to our facility to work with the therapist that's doing the evaluation. And then we work as a team to figure out what are the needs of this particular wheelchair in order to make some recommendations about what we think might be the best type of wheelchair, be it folding, rigid frame, tilt in space, power. And then they also do customized seating. And so they'll come right to the therapy session, take all the measurements, work with the family, the therapist, and themselves to make some recommendations about the best piece of equipment. And then they go ahead and order that equipment. For families that don't have insurance coverage for equipment, that's where with the wheelchairs, the ladies auxiliary can step in and help defray some of those costs so that the child gets the equipment that they need. So hopefully that answered the question.
Great, thank you. We have another question from Dr. Roy Maynard. With the pandemic, what percentage of your visits are virtual versus hands-on?
So as far as the therapy visits go, most of our kids are coming in. And I would like to think that means that they feel safe with the precautions that we are taking. We had, when the pandemic started and we went into more of a lockdown mode, we were doing more of these visits with kids that already had had their evaluation and an established rehab plan of care. We were able to kind of shift those remaining visits that were on their already established plan of care to more of a telehealth mode. But as things have opened up a little bit and we know what precautions we need to take to try to minimize the risks of those in-person interventions, via the masking, the cleaning, the distancing, most of our kids are electing to come in person. Now, we have noticed a little bit of a shift once the school year has started, because families are doing more things with a hybrid model for school or with more of an online model for school. And so we've had a number of families that were coming in person over the summer, and now that they're kind of living their online life with their academics, they are transitioning some of their therapy visits to online as well. I would say if I had to break it down to a percentage, maybe 5 or 10% are coming through teletherapy, and then the rest are coming in person.
Great, thank you. That's all the questions I see posted so far. Anybody else have anything?
Sarah, would you like to speak to, I was so impressed with the different equipment that you guys were using, or that folks were making for the kids in the cast area, whether a kiddo needed an adaptation for like holding their hockey stick or their violin. Just speak more to that if you could. I was just really touched by that they were being made for these kids.
Sure. I think what you're referring to is specifically related to our prosthetics department. So some of the kids with limb differences that come here use either an upper or a lower extremity prosthesis. Particularly with the upper extremity prostheses, oftentimes the terminal devices are more of a hook style or a myoelectric hand. And those do well for your general everyday activities, but they certainly can't meet the need of a human hand that can adapt all the different positions. So if a child has a very special interest, such as, for instance, playing the violin, it's difficult to hold the bow with a terminal device on a prosthesis. So our prosthetics department is so creative at really trying to take the interest of the child and customize a terminal device that the child can swap out on their prosthesis so that they can participate in whatever activity it is that they're interested in. So another thing I forgot to mention, because this isn't really teletherapy per se, but our therapy department also does a lot with specialty camps for kids. So we do provide opportunities for kids to come together. Hopefully next summer is when most of the camps take place. We'll be able to have our in-person camps for various groups like kids with limb differences, and get a chance to bring those kids together to do activities. We have a Camp Bravo, which is a theatrical based camp. We have a Camp Real World that helps with transitioning for the older kids from, that setting of being more with mom and dad and transitioning to being a little more independent with their living situation. So it's another kind of specialty thing that our rehab department does provide.
Great, thanks, Sarah. I don't see any other questions posted.
Oh
wait, here's one more from Bill Wall. Do you have
there was just one through on the chat that asked if we have a list of the camps somewhere in a.
Do you have a list of the camps you could share with the links, or do they need to go through you?
That's a great question, and I can answer that one. So we do have a list of camps that I am more than happy to send along to Teresa, who can distribute that to everyone. With the camps, the patients do need to be Shriners patients, so we do want them to be a registered patient with us to be able to participate in those. But once they're at that point, they are open and able to participate in any of those camps that Sarah mentioned. It's an awesome, awesome opportunity. I myself have only been with Shriners for a little over a year, and that was one of the first things I learned about. The summer I started, they had, within the first month, Camp Bravo put on their performance, and it was just such an awesome way to learn about Shriners and to see the type of patients that we work with. So I'm happy to send along more camp information to Teresa, who can then share it with you. But if you have further questions about that, of course, reach out to us as well.
Great, thanks, Dana.
Well, I think if there aren't any other questions, here we are at 12:46. So we did a great job. Dana, Sarah, Allyce, thank you so much for your time today and for sharing this information with all of us. We really appreciate your time, and I think it was just a lot of great information.
Thank you so much for having us. We very much appreciate your time.
Thank you, everyone.
Thank you.
Thanks, everyone. Take care. Have a great day.